So we prepared with Philippe three cases, very short cases, in order to discuss three different situations for NIV monitoring. So, of course, your contribution is very important, and we will ask to the audience to discuss what is the best monitoring for each cases, and I will note the proposition and debate with the panel of experts. So this is the first case, which is a COPD patient with hypercapnic acute respiratory failure. Is on NIV, of course, it's the purpose of this thematic this morning, with a facial mask, with an NIV ventilator, type BiPAP, or another one, a blower, a turbine. The setting of the ventilator are shown, pressure support ventilation, 15 centimeters of water for the inspiratory pressure, a PEEP level of 5, FiO2 of 40%, because as you can see, the arterial blood gases are not very severe as regards oxygenation, but there is an hypercapnic acidosis. So the question is which is the most adapted monitoring for this patient, and I think that it's important to discuss for which purpose. So which monitoring to do what?
May I ask first where the patient is?
Okay. The patient is in the ICU.
Just arrived.
Yeah, it just arrived in the ICU. Yeah.
Not outside the ICU, then?
No, in the ICU.
And this is the first blood gas analysis, and it just started in NIV.
Or is
Yeah,
it
it's just before starting NIV.
just before starting another?
Yeah.
Okay.
The neurological status is okay. He's a little
He's
bit
confident,
sleeping, but it's
okay.
okay.
Is arousable.
Looks like.
Come on.
Ah.
Must be.
Okay, so it's time to get to work, ladies and gentlemen. So who would like to suggest an answer to the question? I'll bring the mic over to whoever has an answer to the first question. Which type of monitoring would you suggest?
Perhaps first non-invasive cardiovascular monitoring. No heart rate, non-invasive arterial blood pressure seems quite simple, and no, you need to know if the patient is tachycardic, hypertensive, because may be necessary to treat cardiovascular dysfunction if it's apparent or clinically suspected.
But
Okay, so we have non-invasive cardiovascular monitoring. Yes?
This is very important to know if this patient is a purely a respiratory patient or does have other underlying diseases.
No other disease. It's purely a COPD decompensation.
I can tell you that often these kind of patients we keep in the ward and treat them outside the ICU.
I'm sorry.
No.
He's already in.
Yeah, okay. Never mind.
Too late. We can't kick him out of the ICU right now.
The
So,
CO2 is too high and the pH is quite normal. So that, well, I mean, it's not, it's not normal, but it's safe, but not related to PCO2.
Maybe I
PCO2 was
propose
high
to
before.
discuss the specific monitoring for the ventilatory parameters for the respiratory status. What is the first goal of the monitoring as regards the effectiveness of the efficiency of the non-invasive ventilation, which we have to look. What we have to look to.
PCO and pH.
I would suggest the capnography to see if he is obstructive anymore.
Capnography?
Yes.
Okay.
anyone else? While I'm here?
Pulse oximetry?
Pulse oximetry.
Yes,
There was someone over here.
He's already on. Is it okay?
No.
It's not oximetry, that one. This is from the blood gas.
Jean-Christophe, I would recommend to measure the respiratory rate. This is usually the first sign to decrease when we use non-invasive.
PO2, if the PEEP is working, you know,
I
PO2
think
will increase.
we have to examine the patient first clinically. Do he have any neurologic problem, expiratory problem, obstruction, anything? Afterwards, we can start to other clinical monitorizations like tidal volume, frequency, etc.
But I think that all of us agree that the clinical monitoring, together with the objective monitoring, heart rate, respiratory rate, and blood pressure, are essential. This is the basic.
Okay, okay, so...
Expiratory volume, right. The patient is on the mask
We are
and can
discussing
can work.
about ventilator monitoring, then is essential expiratory tidal volume, at least.
So a very important point that you said is to monitor the tidal volume. The monitoring of the tidal volume, of course, is very important to check the improvement in terms of gas exchange. If the tidal volume increases, probably the PCO2 will decrease. Otherwise, if the tidal volume doesn't change, there is no risk that PCO2 decrease. So it's very important point. Other
what about transcutaneous CO2? So,
We mentioned yesterday.
yeah, I remember.
Thank you.
Congratulations, you were awake.
But honestly, who in the room is able to measure routinely transcutaneous CO2 in an adult? Yeah, I think 2, 3, 4. Very good. So it's a good monitoring, maybe, but it's not realistic in daily life. At least not actually.
I disagree.
Because it's not available, Amal. I don't have any machine. I can't. I have 42 beds. I can't.
I don't see your point, Michael. It's a very simple system with an ear probe where you have both saturation control.
There are many, Laurent. There are many simple systems, but they are still costly, and it's you have to have them. Simply spoken.
Michael, it doesn't mean that you need to apply this kind of monitoring to all patients, but just to those who are on non-invasive ventilation.
You have to buy one. Yeah.
Let's take Michael's point. To use the monitoring system, you first need to have one. Yeah, that's good.
That was my most important point.
Okay.
Can I suggest something even more simple? What about a chest X-ray? To exclude any major pathology like pneumothorax before you would put NIV on anyway.
Okay.
I hope that the chest X-ray should have been already done before being admitted to the ICU.
Not necessarily.
Not necessarily, but...
Okay. So maybe we can move to the other case, and after that we rapidly summarize different approach. So the second patient is not at all a COPD patient. Is another situation, is a difficult to wean patient extubated from a few hours before after passing a successful spontaneous breathing trial, and the NIV is indicated as a prophylactic indication with a facial mask, ICU ventilator with NIV mode, pressure support ventilation, and probably the question is a little bit different because there is no hypercapnia, there is no neurological impairment, the cardiovascular function is very well as the respiratory status, and maybe the question is more focused on the tolerance of NIV as a prophylactic technique and asynchrony, etc., etc. Did you have some recommendation different from the previous case for this specific patient?
I have a question. When this chest X-ray was taken?
Sorry.
Before,
it's not good. It's the third case.
It is before extubation is worrisome.
Sorry, forget this. Sorry. This. During the round this morning, I was a little bit, it's not the patient, it's the other one. So, Did you suggest something different?
I wish we could do that in real life. So no,
Yeah.
this X-ray is too bad.
So, of course, for this patient, there is a non-invasive hemodynamic monitoring. But did you think that something is very important to add in this very specific situation? I don't know. Maybe it's not a good...
Any suggestions?
Why do you consider it's difficult to wean patient? Is it because of weakness, heart failure, or what?
Because he's extubated after several attempts of spontaneous breathing trial. There is some hypercapnia, long ICU stay, and so there is we consider that there is a risk of reintubation, but maybe not. I don't know. So,
any suggestions?
Yes.
No.
Again, clinical evaluation more important. His neurologic situation, cardiovascular situation, respiratory rate, accessory respiratory muscle usage, and effectiveness of ventilation. Beforehand, other monitorization. Then we can start to monitorize other parameters.
Okay.
Thank you.
No?
It's maybe the preceding patient ventilation, sufficient ventilation was really the key point, and looking directly or indirectly with respiratory rate. Here, it's we suppose that the patient is okay because we decided to extubate, but then the risks are the poor tolerance, secretions, and it's really not, maybe less looking at the ventilatory parameters and more looking at the clinical situation of the patient and secretions. And unfortunately, we don't have monitoring tools for secretions.
For non-intubated patient, there is something now for the intubated patient which is just a sound.
Don't tell Michael.
Okay, okay, okay. I will not.
No, it's cheap. I can.
So, okay, so maybe it's the most... yeah, Greg?
The one thing I might add as well is I think, and it's sort of what Laurence is saying too, is that it depends on why the patient was difficult to wean, as they were saying. If the patient has coincident cardiovascular disease, your monitoring may focus on that, but if the patient had chronic lung disease, COPD, or obstructive sleep apnea or obesity hypoventilation, you're going to monitor acid base and arterial blood gases and other things. So, you know, a lot of it is very clinical, but it's going to depend on the comorbidities or the other condition that led to the chronic weaning problems.
Okay. So okay.
I would try to look at the respiratory-related excursions of the central venous pressure to see as a surrogate for esophageal pressure, which I'm too lazy to use. And that would be a good way to see whether the PEEP level and the pressure support would be enough, and you don't need to put any new lines in. Isn't that the problem here?
Okay. So maybe everybody is okay to say that in contrast to the first patient in which the monitoring of the respiratory parameter it was very, very important, for this patient is more the clinical status, the tolerance of NIV, that will be very determinant. Okay, so rapidly let's move to the last case, which is also completely different. It's the other unit of the same, other room of the same unit. 45 years patient with acute respiratory failure may be related to a very severe pandemic flu with no other comorbidities. The respiratory rate is very high because of very high respiratory drive. The hemodynamic status is correct. NIV is started as much as possible with a facial mask, an ICU ventilator with the NIV mode, and this is a setting at the beginning of NIV. So what is the purpose of the monitoring for this patient with a hypoxemic respiratory failure? What is different from the first and the second case, to your point of view?
For how long is the patient on non-invasive ventilation?
It just arrived with the other one.
I see. So it's this is the starting point.
Yeah, this is a starting point.
It's a very busy day at the ICU. Everybody's arriving at the same time.
As usual.
As usual.
So maybe what is the point for this patient? Did you have some suggestion? How many people want to intubate this patient? Okay.
Impressive.
How many not patient? How many people say no? We have to try with NIV.
You don't know what the PO2. We don't know.
Okay. Okay. So
for those
the
of
arterial
you,
blood gases are determinant in order to decide.
Yeah,
okay.
Of course.
Okay.
So for those of you who want to try NIV, how would you monitor? You said PO2, so arterial blood gases. Any other suggestions? Okay. You want to use what?
Respiratory muscle monitoring. Clinical then.
Oh, okay.
So clinical assessment of respiratory failure. Okay.
By the way, my personal recommendation is not insist too much with this patient. If the patient doesn't improve within 1 hour or even
your message.
a little bit more, do not hesitate to intubate.
But are you agree with the fact that we just start and that maybe in some patient that will be...
That's what I do, for instance.
So the question is what will decide the clinician to stop NIV and to switch from intubation? And this is the question of the monitoring. What we have to monitor in order to decide to pursue or to
Jean-Christophe, we had a suggestion here to monitor extravascular lung water.
Okay.
Why not? But maybe this is not, maybe interesting, but not essential.
Okay, it was a suggestion from the room. I convey it to you.
Arterial blood gas analysis in this case is absolutely unrenounceable.
Because I think that monitoring extra lung water will not help you to decide to stop or not the NIV.
I would like to know about lactate.
Blood lactate? Okay, okay, very good. Everybody is okay with saturation, continuous monitoring. It will be essential when you...
If there is already a CV line in, central venous saturation. Maybe very helpful. Yeah.
Central venous saturation. So I need some help to do my round because I'm... How do you deal with for this patient? What is the information in a practical point of view that...
If it's about... The information is about the cardiac output is enough or not. So you see the heart failure or not in this patient. So you will improve, just applying positive pressure will improve in a cardiogenic edema and maybe not in an acute respiratory failure.
Okay, so the change in central venous...
just to see what's the SVO2 right now, to see if below 70 or below 60 maybe. So if it's due to cardiogenic edema, you know, the patient is going to improve in just half an hour.
Yeah, so maybe we also perform an echography to check...
Correct.
Okay.
Echography may be very useful.
I think it will be pretty hard to lay down this patient to put the central IV line because he will not tolerate it at all.
If we're using an ICU ventilator, why don't we turn the dynamic loop on? Because it will, if we want to stay with NIV, then we at least can see how high we can go, we can see the effort, we could see the compliance of the systems, and we can see if there develops any leaks, because then it would loop off the screen. It's so simple to do. And if we can't then kind of give the patient what he needs, then he needs intubation. But it's there, so why not turn it on?
Okay, okay. Okay, so we have to stop. Just 2 words to summarize. I think that the first patient, we have to focus on the clinical status, but also on tidal volume respiratory rate to assess the improvement under mechanical ventilation. The last patient, the critical point is to decide or not to intubate the patient based on the clinical status, arterial blood gases, continuous saturation, on also respiratory parameters, tidal volume, and the other patient is a different case, which is for each, the clinical assessment is very important, most important. So thank you for the discussion.
Maybe because it was mentioned, if you use an ICU ventilator, as Philippe said, please switch on the NIV mode and use the facilities of monitoring, because they monitor the leaks, the amount of leaks by comparing expiratory to inspiratory tidal volume. This is very useful.
Okay.
So, and in this patient, maybe in the first one, it's important to increase tidal volume. In this one, maybe it's important to see that the tidal volume is not too high.
Okay.
But I will really try non-invasive ventilation in this patient. It will work.
Yeah.
And one final general comment, I think it's very reassuring to hear from the room that most of you remind us that the first thing to do is to look at the patient, the respiratory rate, comfort level, and I think it's reassuring to see that we are still all clinicians despite the fact that we have a large array of technology to help us monitor the patient. Thank you very much for your participation.